Good evening, everyone. Is that on? Yes, thank you. I'm Professor Rob Saint. I'm the Deputy Vice-Chancellor of Research at the University, and in fact acting Vice-Chancellor today because the Vice-Chancellor is overseas, and I'll be your host for the evening. I'd first like to acknowledge that we meet on the lands of the Kaurna people and pay respect to their, excuse me, people of the Adelaide Plains and pay respect to their elders past, present and emerging. We recognise and respect their cultural heritage, beliefs and relationship with the land that continue to be as important to them today. Now, before we commence the evening, please note that the emergency exits are located outside of these doors. Please follow the stairwell down to the plaza area, and the meeting point is outside the plaza. Facilities can be accessed outside of these doors through the glass sliding door and turn right down the hallway. Where's the glass sliding door? Okay, I'm just giving you the facts. So welcome, and thank you for joining Flinders for this research lecture series entitled Brave. If you wish to share the event with your peers, please make sure to hashtag Brave Research into your posts or tweets. Brave is not just a reflection of the extraordinary research that Flinders University pursues today. It's a call to action that harks back to the earliest days of our institution. As we at Flinders make inroads into our mission to change lives and change the world, we focus on making a difference by extending the boundaries of knowledge, by addressing the big challenges, and by changing lives for the better through our research. Our founding Vice-Chancellor, Professor Carmel, explained his ambitions for Flinders in the now famous quote, "We want to experiment and experiment bravely." It's a concept that has captured the imagination of successive generations of Flinders researchers and continues to inspire us today. This bravery is evident in our researchers and in the research discoveries that we're sharing with the world for the greater good. Tonight, we'll discuss improving health through the science of sleep. 4 out of 10 Australians either do not regularly get enough sleep or they experience disrupted sleep due to a medical condition or sleep disorder. At least 1.5 million Australian adults suffer from insomnia or have the sleep-related breathing disorder, sleep apnea. Professor Danny Eckert will discuss with us tonight new horizons in sleep disorders treatment and management, covering recent discoveries as well as common sleep myths and facts. Danny is a Matthew Flinders Fellow within the College of Medicine and Public Health and Director of the Adelaide Institute for Sleep Health at Flinders University. He leads a comprehensive basic science and translational research program that focuses on the identification of the causes of sleep apnea, optimisation of existing therapies, and development of new tailored therapies using novel respiratory phenotyping techniques. He's been the recipient of a prestigious Nhmrc C.J. Martin Fellowship and was a researcher at Brigham and Women's Hospital, Harvard Medical School, and at Neuroscience Research Australia in Sydney. Professor Eckert has authored over 110 peer-reviewed publications, probably more since these were written, I suspect, in the leading sleep and respiratory medicine journals, and for the past 7 years has served as research chair on the board of the Australasian Sleep Association, the peak scientific body in Australia and New Zealand, representing clinicians, scientists and researchers in the broad area of sleep. Please welcome Professor Danny Eckert.
Well, many thanks, Professor Saint. Can everyone hear me on the lapel there? Great, because I don't want to leave folks out over here. So I will move around a little. But first, I just want to say that the land on which we stand here below us, learning and teaching's been going on for thousands of years. And so it's a real privilege and honour. And I think Michael summarised that for us very nicely in his Welcome to Country earlier. So I'd also like to pay my respects to the traditional owners, past and present, and future leaders. Okay, thank you for coming to hear about sleep this evening, and I will do my best to challenge some of your ideas and knowledge about sleep. The people in this photo, they know about sleep. They know how important it is, and they're dedicated to helping those who cannot sleep enough or have a sleep disorder. So these are the folks at the Adelaide Institute for Sleep Health with whom I'm extremely privileged to work in our new facility. We've heard 4 out of 10 Australians have inadequate sleep. This is a huge issue for our community. $66 billion in 2017 alone in direct and indirect costs that this has cost our nation on conservative estimates. Hard to think of another medical condition where those sort of numbers are quite that large. So much so that this has led to a national inquiry, a parliamentary inquiry that was, and many of us in the room at the Adelaide Institute for Sleep Health were testified as expert witnesses, and it really has come up with a comprehensive list of recommendations on how we can move forward and put our nation at the forefront of sleep medicine and sleep health. So I'm going to talk about 2 things this evening. I'm going to share some sleep facts and address some sleep myths. And then I'm going to spend the remaining time talking about sleep research at AISH, the Adelaide Institute for Sleep Health. Specifically, I'm going to talk about new approaches to sleep disorders treatment and management, and in particular, I will talk about my research focus, which is sleep apnea. I'm going to start by testing your knowledge. How many hours, just have a little think about this question, how many hours do you typically sleep per night? Just have a little think about that. And then I'm just going to ask people, if it's less than 5 hours on average a night, please raise your hand. Yep, some of us. Who gets 5 to 6 hours per night? Yep. What about 6 to 7? Yep, majority. 7 to 8? Okay. 8 to 9? More than 9? Yeah, a few. Yeah. Okay. Sleep duration and mortality. When you ask millions of people, literally across several studies, that very same question, this is what we see. Those who answer, sorry, I won't do that. I promised I wouldn't put my back to that side of the audience. Those who answer 7 to 8 hours live the longest. If you're up on the other spectrum, right here in that below that, A, B, or C, on average, the evidence shows when you reply to that question, you're more likely to die earlier. Now, it turns out every health outcome you can think of would come up there, but clearly how long you live is clearly one of the most important. Interestingly, for reasons we don't fully understand, you'll notice that the curve is also quite high on the other end. So those who routinely report sleeping more than 9 hours on a regular basis also are more likely to die early. Now, on the left-hand side, we understand that, you place stress when you're not getting enough sleep, you're not getting enough restorative benefit, there's inflammatory processes underway, and this makes sense. Maybe it's a marker of other poor health if you are sleeping on more than 9 hours on a regular basis. Here are the recommendations. Adults, 7 to 9 hours per night for those who are over 18 years old. And it really doesn't change. So I guess here's myth number 1. There's some perception that maybe as we age that we need less sleep in our older years. 7 to 8 hours is still the recommendation for people over 65 years of age. Teenagers, they don't get enough. A recent study out of Canada, 15% got the recommended 8 to 10 hours a night. So they're a real at-risk population. Okay, here's another question. How many times per hour does a healthy 20-year-old wake up during sleep? Just have a little think about that. So a healthy university level individual, is it A, they shouldn't wake up at all per hour? So actually just have a think about this and I will get a show of hands again. So who thinks it's 0? Yep, fair few. What about 1 to 5? Yep, majority. 5 to 10? Few. Who thinks D, 10 to 15? What about over 15 times an hour as a normal, healthy? Yep, none. Okay. So here's the answer again. Many studies put together. Correct answer was D. It is very normal for a healthy 20-year-old to wake up between 10 to 15 times per hour. Now, these are not full awakenings. These are brief awakenings, less than 15 seconds at a time. If you measure the electrical activity on the scalp, they're having multiple awakenings. And you'll see on the x-axis here is age. So as we get older, we do tend to wake up more times per hour. Healthy. These are healthy, no pathology whatsoever. A 60-year-old on average is waking up over 20 times per hour, quite normal. So, in fact, sleep is a roller coaster. We're not in this comatose state where nothing is going on, and in fact, lots is happening. We're cycling through these lighter and deeper stages of sleep. On the front end of the night, we tend to have a lot more deeper, or what we call N3 or slow wave sleep, and then we tend to have lighter, but also much more rapid eye movement or dreaming sleep on the second half of the night. Interestingly, if you look at these waveforms. So this when you stick an electrode on the scalp and you measure the underlying electrophysiological activity, as shown here, this is what the brain waves look like when people are awake. Look down here when they're dreaming. Very difficult to tell those two apart. Lots of fast frequency. The other ones we can tell. When you're in deep sleep, you can see here things are slowing down. You've got these ripples like so. The brain activity is quite synchronized. But if we didn't have those other measurements about the muscles being relaxed and the eyes flickering, we couldn't tell whether, it would be very difficult to tell whether you're awake or asleep. The brain is very active during dreaming sleep. Lots of memories and learning consolidation taking place. So here's a little graph across the life cycle that shows what happens. So there are some structural changes in sleep as we age throughout the lifespan. But as I mentioned, the sleep requirements are pretty consistent. Here's minutes here on this axis and age here. So you tend to wake up a little bit more. So these now are awake after sleep onset. As I showed you earlier, you have more awakenings as we get older, completely normal, a little less REM sleep and a little less deeper sleep. But overall, pretty structurally similar, certainly in terms of the total sleep requirements. Another question, inadequate sleep on alertness and performance. How long do you think you can stay awake until you start behaving as though you're intoxicated? So we can measure that in the lab. We can do reaction time tests and simple alertness tasks. So just have a think about what your answer might be. How long in a row do you think you need to... I won't hurt people's arms and ask them to raise them again, but I'll just share the answers with you. You're awake for 19 hours in a row. You're performing at a blood alcohol concentration level equivalent of being intoxicated, 0.05. You stay awake for 24 hours, you're now 0.1. Or you can do it another way. You can get there by 4 or 5 hours a night on a regular basis over a week. That'll get you to 0.1 as well. So as a society, we mentioned those numbers at the start, 4 out of 10 people aren't getting enough. We know these things contribute to car accidents, injuries at work, and of course in the hospital. People are making errors and injuries purely because of the fact that they're not appropriately rested and alert. So here I've got health shift workers. So this is a review from Nature Reviews, and you can take any organ in the body, and in fact any cell in the body. It does not function optimally if it's not appropriately rested and restored. So very powerful sleep, and better than any medicine we can think of, really. Every organ, and I've got shift work here, but it could be a sleep disorder or not getting enough sleep. You'd have the same adverse consequences. And so, yes, our brains aren't functioning. We can't think as well. Our amygdala is 70% more reactive after a single night of sleep deprivation, so we're more likely to make rash, harsh decisions. It's linked to cancer. It's linked to obesity. 17% of Australians are shift workers. This is not an uncommon issue. This is a big issue for our community. So there's just a few common sleep facts and myths. I'm now going to talk about the research that we do over the road at the Mark Oliphant building. We've talked about, we have what we call basic sciences. There was nothing really basic about it. It's complex science to try and figure out why people are getting their sleep disorders, right through to implementation of new treatments and new strategies to get better care for people suffering with sleep disorders. Multidisciplinary team, that really approaches all fields or all areas in the college, across the college scheme here at Flinders. And I've highlighted just some of the many sort of high-level publications that have come from the team and some of the translational developments, certainly from FIM. This is a treatment that was designed, the little device you can wear on your finger here to treat insomnia. We've got Retimer to get rid of jet lag and people that have disruptions in their body clock. We've got these fundamental science, studies, these randomized trials that show that nurses and GPs can deliver equivalent healthcare to a sleep specialist if appropriately trained, as well as some of the insomnia interventions and basic science, figuring out how these reflexes and muscles around the airway work. So it really is a very comprehensive, broad program. So I'm now going to talk about sleep apnea and just highlight some of the issues there. Our welcome to country presenter, Michael, told us about you've got insomnia and sleep apnea. That's a double whammy. That's really difficult to deal with both of those. In the US, estimated effects over $150 billion in 2015. So this is motor vehicle accidents, it's workplace injury, lost productivity, and we know that these things, as I mentioned, are bad for all the organs, bad for the heart, more likely to have diabetes, be obese, and so forth if you've got untreated sleep apnea. This is a study that just came out in Lancet Respiratory Medicine. Over 1 billion people on the planet are now estimated, or approximately 1 billion people are now estimated to have some form of sleep apnea, and half of those, moderate to severe sleep apnea. So this is a huge global problem that we're facing. In case not everyone is familiar, I'm just going to show you what sleep apnea is like. So here's this individual here, middle-aged man. As you can see, slightly overweight. He's now gone off to sleep. He's completely stopped breathing. There's a pause. Everything's quiet momentarily. Over time, you'll see that the chest and the abdomen start to move in opposing directions, what we call paradoxical movements of the chest and abdomen. There's no air whatsoever going through this throat area because the airway is completely closed off. It's shut. He's still trying to breathe. His CO2 is going up. His oxygen levels are going down. There's stress being placed on the heart. Fast asleep, making big efforts to breathe, sucking hard, and eventually he's woken up. He's had one of those arousals that I talked about at the start, woken up for 5 or 10 seconds, taken a few gasp breaths, gone back to sleep, and it happens over and over again. Now, not surprising, you feel rotten if that happens to you every night on a regular basis, and it is clearly a very serious medical condition. Sometimes this can happen 100 times or more per hour in a severe case, and with very low dips of oxygen. So why do we need new therapies for sleep apnea? Australia has been a real innovator in sleep research and sleep medicine. Now, this is alarming to the sleep researchers in the room because it is very unrealistic on a number of levels. And I'm going to say is straight up poor sleep hygiene. Firstly, blue light emitting device reading as you're about to go off to bed. That's the same as having a being out in bright light in the middle of the day, which we know suppresses your melatonin, stops you from going to sleep. Problem. Secondly, mouth open, reading in bed with the CPAP on. That's going to sound problematic. The air is going to flow straight out your mouth. It's going to rattle around, and it's going to be like snoring, basically. So that's and also, yeah, not the typical. Look, everyone, thin people get sleep apnea too. We did a study a few years ago. 50% of people that get diagnosed with sleep apnea are not obese. Women get sleep apnea too. So the stereotype that it's overweight, middle-aged men is not completely true. Yes, they are major risk factors, but this affects everyone in our community, and of course children too, who don't perform well in school when they've got untreated sleep apnea. So, yeah, before I say that, so developed here in Australia, continuous positive airway pressure therapy, putting the mask on, blows open the airway, works fantastically well. Millions of people around the planet now benefit from this therapy developed here in Australia. If you can tolerate it, fantastic. but yes, a little crude. You know, this was developed in the 80s, and Colin Sullivan would be the first to say, you know, very surprised that this is still the first-line therapy for this common sleep disorder. So our hope, and others at AISH, is that we can do a little more than just, as fun as it can be blowing air in the airway, we're going to do a little more than that for all the people that cannot tolerate the continuous positive airway pressure therapy. We know that this current one-size-fits-all trial and error approach is cumbersome, time-consuming and costly for the healthcare system, and it's really failing too many patients. This is a heterogeneous disorder, and so the optimal therapy, or therapies as the case may be, likely varies between patients. So this is what our precision medicine research program is all about, giving the appropriate therapy to the appropriate person. So here's a breakdown of, I just want to share the patient journey. So if you think you might have sleep apnea, perhaps it's your bed partner that has alerted you and they've noticed that you've stopped breathing. Perhaps you've woken up with headaches and just not feeling optimal in the morning. First you might chat to your GP. They may refer you to a sleep specialist. There'll be a wait involved there. Remembering that how many people this involved, the system cannot cope with the burden of disease. Technologies have advanced, so now we can do many of the tests in the home, where before you had to come into hospital or a sleep laboratory, but still the gold standard is in the sleep laboratory, but many are now occurring in the home. You then need to wait for, somebody has to go along manually and look at every single breath throughout the night and decide whether you're awake or asleep and whether you're breathing appropriately or not. That gets reported, you see the sleep specialist, and regardless, if you've got sleep apnea, more than 5 breathing stoppages or 10 in some cases, depending on the definition, you will be more than likely prescribed CPAP therapy, and you'll go on for a trial of CPAP. It is really the minority of people that go on to other therapies, such as dental mouth guards to pull the jaw open. And this is despite the fact that the evidence shows that they can deliver equal health outcomes. So then you'll go on, you'll have a CPAP titration, work out how much pressure you need to blow in the airway to keep it open. This is another sleep study. Again, technology has helped. You can now do this in many cases with an auto-titrating device, but traditionally this has been done in the laboratory with a technician working out exactly what pressure you need. I already mentioned that half the people that try CPAP therapy fail it, can't use it. So then they've got to, you know, you can imagine that people are falling off this at many steps along the way here. If you're really determined, you come back and you see the sleep specialist, you might be recommended another therapy or go on to an oral appliance. And again, the problem with these oral appliances is multiple visits to the dentist, toss of a coin. We cannot predict who's going to do well on one of these devices or not. It costs you about $2,000 on average. Those it works, fantastic. Those it doesn't, you've spent a lot of money, and would be nice to have known that ahead of time and be able to apply the appropriate therapy up front. So really, what we're trying to do is slim this down by coming up with new therapies as well as new ways to diagnose and treat this common disorder. The Nhmrc Centre for Research Excellence, headed up by Professor McAvoy and the team, the National Centre for Sleep Health Services Research. So this CRE developed because of all the clinical trial and translational work that occurred at AISH. And it's really about developing new, simplified, cost-effective technologies and systems for education and diagnosing both sleep apnea and insomnia at the primary care level. So really upskilling the GPs to handle this, common condition. Here are the folks involved. It is a national endeavour with many skilled people from across a range of disciplines involved in this endeavour. Pharmacists, nurses, GPs, scientists, as well as sleep physicians, health economists, and so forth. So now I'm just going to focus back on the sleep apnea side with the work that we've done, and it's really been about figuring out, so in order to deliver this targeted or precision medicine therapy, we've had to work out why people get their sleep apnea. And this is just a summary slide of now what we believe is the gold standard of what's going on. So we used to think it was just having a bad airway or a narrow upper airway that was the cause of sleep apnea. We now know that there's these 3 non-anatomical causes as well. Muscles in the airway don't work properly to keep the airway open during sleep. You can be one of these people that's just a light sleeper. You can't get into deeper sleep where your breathing tends to become more stable. and others are just too sensitive to changes in carbon dioxide, what we call high loop gain. And here's just another way of showing that information. So to get sleep apnea, you have to have some degree of anatomical compromise. So perhaps your jaw is what we call retrognathic, is back a little bit here. Perhaps it's just anatomically narrow. Perhaps you've got some obesity that's crowding the airway. So you need some degree of anatomical compromise to get sleep apnea. But it varies substantially. Some people just have a little bit, others have got really collapsible airways. Turns out a third of people have a problem with this waking up too easily issue, what we call a low respiratory arousal threshold. A third have unstable control of breathing, that high loop gain, just too responsive to changes in carbon dioxide. So when you're asleep, carbon dioxide controls your breathing. If you have too little, you will stop breathing. And that doesn't happen while you're awake. You've got all these other systems in place to allow you to continue breathing. So very small changes actually in carbon dioxide will turn off the parts of the brain that tell you to breathe. So if you're waking up, what happens is you have these big breaths, you blow off the carbon dioxide, and that can set you up for this cycle of unstable breathing. And lastly, a third of people have you've got over 25 muscles around the airway that keep the airway open. This is great, allows us to swallow, allows us to speak and do all these other tasks, but when the muscles are relaxed during sleep, this is a problem because they can also close off the airway, as we saw in that gentleman in the video. And it turns out that 70% of people with sleep apnea have one or more problems of these non-anatomical features. And this has really been the latest advance in this phenotyping work that myself and others have done over the last 10 years in this area. Here's another way of showing that. So if you are over here, you can see on an MRI scan, here's someone with a nice wide open airway. If you were to take a snapshot of that, you would say, okay, this person does not have sleep apnea. This person's got a crowded, narrow airway. You can see the bands of adipose tissue or fat here in the tongue, the largest dilator muscle, and this narrow airway here. But if you were to just look at that, it's not the full story. You can overcome this narrow or anatomically narrow airway, just taking the static snapshot here in the fMRI, if your muscles are excellent. So some people have the ability to use these muscles to keep their airway open. So even in some people who might be quite obese, their muscles are working well, keeping that airway open, as we can see in this MRI image here, and they're protected from sleep apnea. Other people, things are very crowded and there's really nowhere to go. You can see the tongue, or this is the genioglossus muscle here, is trying to move forward, but it's got nowhere to go, and it's having this counterproductive movement, and the uvula, the flappy bit here, is actually falling back on the posterior wall, the back of the throat, and causing issues in here. This is what we call counterproductive motion. And here's another person who actually has very severe sleep apnea. They're not moving the muscles at all. You know, this is quiet breathing awake, and they're hardly moving it at all, and their airway's very narrow. So it just takes a little bit of muscle relaxation, and they're going to have severe sleep apnea. Okay, so different ways. Now I'm just going to show you some of the interventions that we're doing on the targeted treatment side. So this precision medicine approach. And I'm just, for the sake of time, I'm just going to show you one example on each. We've got programs on each of these arms aimed at tailoring therapy. So this is a part of the CRC that I head up, the clinical arm, a cooperative research centre that now Flinders has become a partner of. And I mentioned at the start, these devices, you can get fitted by a dentist. They work very well at pulling the jaw forward and keeping that airway open. But it's very difficult to tell who it's going to work in ahead of time. So you've got to actually try it, unfortunately. So this leaves that other 50% who have already often failed CPAP. They've tried other things, left with very few options. So what we've done in this study, very simply, this is a slightly novel device, a Brisbane company, and is a partner in our CRC. They've got an oral airway, so you can still breathe through the device through your mouth. And what we've done here, so here's the severity of sleep apnea, the number of times per hour the airway is closing off. So these people with moderately severe sleep apnea, about 25 times an hour without any device in place. These are, by design, these are the people that did not respond. They've still got about 20 events per hour when we put one of these devices in. All we did now is come along and put a little valve. We put a little extension on the oral mouthpiece to make it a little harder to breathe out. And we've now treated a bunch of people that weren't treated before. And then when we put a little bit over the nose as well, you can still breathe in just as easily, but a little harder to breathe out. So that creates some positive pressure and enlarges the airway. We've treated a bunch more people who otherwise weren't treated. So this is a very simple addition that these people could now have, and this is about to come on the market, I think, next month. And that's all from research that we did in our CRC. Now, this one's a little strange. So we used to think it was malpractice to give a sleeping pill to someone with sleep apnea, but as we've learnt more about why people get their sleep apnea, and we figured out that actually a third of people are waking up too easily, we rather boldly tested, well, actually, can we give them a sleep promotion aid to actually help these people? And it turns out the answer is yes, to some degree. This is how we measure how easily people are waking up. And I haven't gone into all the detail as to why this is a problem for their sleep apnea, but let me just say that if you're a light sleeper, you can't get into deep sleep, and this causes problems. You wake up all the time, you can't get the muscles working, and it's a problem. So when you give this common drug, ezopiclone, we're able to increase the pressure that you can generate before you wake up. So harder to wake up, basically. We didn't take people that have got bad oxygen levels to begin with, because this can make things worse. So we deliberately avoided those people in this small randomized trial. With people with a moderate arousal threshold, didn't change their sleep apnea at all, but those who were the ones that woke up easily had about a 40–45% reduction in their sleep apnea invariably. And in fact, their oxygen tended to get better, not worse, when we did this. So we've done a number of studies that have followed on from that, including work that Jane Carberry's done, who's now here at Flinders at AISH as well. And she's actually found a target drug that it not only doesn't relax the muscles, which we were quite worried about, she's found one that increases the muscles threefold. So what about other things for the people that are too sensitive to carbon dioxide? Here's a study that my colleague Brad Edwards did when he was in Boston with us, and basically he combined oxygen. Oxygen helps you become stabilize your breathing in those that are too sensitive to CO2, and he combined it with one of those sleeping pills. So here are two non-anatomical interventions, and we can see we try to get people below 10 events per hour. We've treated many people. These are just unselected people with that combination. And finally, this is one that I'm really excited about now. We do not have any drugs to treat this disorder at the moment. We've in the lab have been very carefully studying how these muscles work in the hope that we will find some targets so that we can do this. So this is the fundamental thing. As I spoke about, sleep apnea is an interaction between how well your muscles are working and your anatomy around your throat area. So if we can identify what causes these reductions in muscle activity when people go off to sleep, we should be able to give a drug or drugs to keep the activity higher and stop it. Now, 40 years of research, we have not got there, but I think there's a real reason to be excited at the moment. So we used to think that serotonin was the thing that we should be targeting, and there were clinical trials in humans that, based on animal work, that tried that, didn't really work. And the reason because the animal preparations were too minimalized and they didn't actually translate to the humans. What Rich Horner and his colleagues have done in Canada now is actually, basically they've been able to record in freely behaving animals and put little bits of these neurotransmitters into the area that controls these muscles. And he's found that these two agents, noradrenergic agents during non-REM sleep and antimuscarinics during REM sleep, are really important for determining how much muscle activity you have. So look here. So this is the muscle activity on these muscles here. One here, the purple one, and the base of the tongue here, shown on these recordings. You can see here this person's awake, lots of activity. This is the very second they've dozed off to sleep. This is a sleep transition, we call it. They've gone to sleep right here, and you can see immediately the muscle activity goes down by 30–40%. So it's not surprising. Many of us might experience that where you just drifted off to sleep, and that's because the muscles have very suddenly lost their activity. So what we did in this study with my colleagues in Boston is we took existing drugs with known safety profiles that had those properties that targeted the noradrenergic and the antimuscarinic system, and we just combined them, and we looked at what it did to the muscles, and we looked at what it did to their sleep apnea. Now, we tried many things. This was the one that actually worked. Basically, we were able to increase the muscle activity threefold with this combination, and we had substantial benefits in their sleep apnea. So their sleep apnea severity was reduced from over 30 an hour down to 7 or 8 per hour. So major reductions in their sleep apnea severity, both during non-REM and REM sleep. And also their oxygen levels got much better as well when we did this combination. So this is very exciting. In my lab in Sydney at the time, we were, Richard Lim was doing his PhD in this area. He's about to come over here later in the year as well. He studied another drug with similar properties, reboxetine. It's actually an antidepressant. Those other drugs that I showed were ones that are actually used for attention deficit disorder, hyperactivity disorder. This is actually an antidepressant, not a particularly good one in terms of treating the depression, but a very safe one. And what we've shown here is increases in the muscle activity around the airway of the tensor palatini and reductions in sleep apnea severity as well with this combination. So there's just a few snapshots of what is quite a large program of work, and here's a summary slide that my colleague Jane Carberry put together. So we used to be here, anatomical interventions for sleep apnea. Certainly I haven't talked about surgery, another major clinical trial led by Nick Antic and Doug McAvoy, the results of which have just come out that's shown that this can help many people as well. Certainly weight loss helps, sleeping on your side can help, and I talked about those mouth guards, how that can help with the anatomical problem. We now have these other arrays. You can actually train the muscles. I showed you some drugs. You can provide electrical stimulation to these muscles, oxygen and certain drugs to deal with the CO2 problem, and other drugs that we're working on to stabilize sleep. So here's what we're trying to move away from is at the moment, the way we define sleep apnea, mild, moderate, severe, is simply by counting the number of stoppages of breathing per hour. It's very crude, and it doesn't actually help us with our treatment decisions at all. It's, as I mentioned, 50% failures with the first-line therapy. So here's the model that we're working on and proposing. If we knew those 4 causes that I showed you at the start very accurately, or at least had good estimates, we could then deliver 1 or more therapies. Asthma, we give combined therapies. We give a drug to open the airways and work on the muscle as well as one to reduce the inflammation. We don't do that in sleep apnea at the moment, although we know it's multifactorial. So there's a lot of scope to combine therapies as we've started to do in some of our research. So we're moving away to this sort of precision model. And I just want to finish by showing some of Amal Osman. She's going to be on the panel afterwards, some of her recent data. She just won the New Investigator Award at the Sleep and Breathing International Conference in Finland. And what she's done here is taking that, again, if we knew one of the traits, you'd want to know how bad the anatomy is, so that people that only had a little bit of an anatomical problem, that is their airways not too collapsible, you could try one of these alternative therapies, whereas those when it was really bad, you'd want to go straight on to CPAP. And all she did here, knowing that people already come through on that treatment pathway to work out what pressure you need, your CPAP pressure, she just turned the pressure off for 5 or 10 times at a night as part of a standard sleep study. And what she was able to show is that she can determine with a high degree of accuracy who's got a bad airway and who does not, just by doing that simple test and measuring how much airflow you have in response to that. So a really practical, easy thing that you could actually implement, and this was funded by the CRC for alertness, of which Flinders was a founding partner. Okay, so I might finish there, and thank you all, and of course wish you a fantastic sleep, and I think we're doing some panel discussion now.
Thanks, Danny. That was absolutely fascinating. Now I'm going home and going to bed.
Yeah, good. Yeah.
No, not yet. So we do have another part to this, and it is a panel which will be open to questions from anyone in the audience. So Danny is joining us on the panel. Professor Doug McAvoy is joining us, Dr. Nicole Lovato, and Amal Osman. And congratulations, Amal. That's really fantastic achievement of yours. So please come up, take a seat. There are roving microphones. So if you have a question, please wait till the microphone gets there, because we're taping this, and the people watching it won't be able to, or streaming it, whatever we're doing, won't be able to hear the question until the microphone gets to you. So I introduced everyone, didn't I? I hope. Yes, thanks. Do we have any questions from the audience? Maybe I'll start with one because it's my understanding is it's still not very well resolved. Why do we sleep?
I can answer that. That's easy. Because we get tired. No, but really, if you don't, you die. Yeah, you throughout the day you get a lot of neurotransmitters that build up. Adenosine, caffeine is an adenosine antagonist. So you take a cup of coffee, and that's why it makes you more alert, is because it's getting rid of that adenosine that's building up in your body. So now, of course, philosophically, there's other fundamental reasons as to why we need this restorative process every night that we don't fully understand. But we sleep because we get tired. we need it. Yeah.
Thank you. Any questions?
This is probably going to seem like a stupid question. Are you saying that everyone who doesn't sleep for 7 hours must have sleep apnea?
Go ahead, Amal.
No, so if you sleep for a lot less than 7 hours or a lot more, long term it could be bad for your health. But regarding sleep apnea, that's more your airway is narrowing when you fall asleep, so all of the muscles in your body relax when you sleep. And like Danny said, you have over 25 muscles that work to keep your airway open, but when you sleep, they relax as well. And if you have a narrow airway, then you're more likely to have closure of the airway. And so you're not getting enough ventilation. And so that's what sleep apnea is.
Could I ask another question?
Sure.
I think you said if you needed a test, you used to have to go to a laboratory. It can be done at home. Now, I'm by myself. My teddy bears don't tell me I'll snore or wake up.
Yeah.
I don't want to go to a sleep laboratory. Can it be done at home? I don't think I've got it, but I could be.
Go ahead, Doug. That's you.
It certainly can be done at home, and I think the majority of people now who are having a sleep test for sleep apnea, it's done in the home. It's more the complicated cases, people who have other medical conditions or who are, frail and unable to, assist themselves, turning on the buttons and so forth to make it happen at home. But it can certainly be done at home. And one of the big pushes, if you like, that we've got with this Centre of Research Excellence trying to help GPs manage sleep apnea is we think it could actually be done very, very simply in the home. Without a lot of wires on your head to measure your brainwaves and so forth, we could actually do it very simply. So we've done quite a lot of preliminary research, and now we're trying to roll that out in general practice. Yeah.
Thank you. It's a very interesting area. I just wanted to ask a question. Just evolutionarily, we seem like a pretty weak species if 50% of us can't breathe at night. What is the evolutionary advantage of your muscles relaxing more at night, do you think, or is there one?
I mean, it's a carryover from not wanting to act out your dreams, which could hurt yourself and others. So the way the switch works is because all those memory and learning is taking place when we're particularly in that rapid eye movement sleep, which is when we do most of our dream. Turns out we do dream in non-rapid eye movement sleep as well, but that's quite recent research that's shown that quite clearly now. But really, your muscles are relaxing all throughout the body so that you don't, act them out and cause harm to yourself and others. So this is a carryover. It is certainly a part of our aging as a species. Wasn't a problem when we weren't living that long evolutionarily, as well as, of course, the obesity epidemic, and our structures are changing. In Asia, it's for a given level of BMI, the sleep apnea is much more severe because it tends to be driven by these craniofacial differences and the way that it crowds the airway. So it's just bad luck, really. Yeah.
Thank you for that. Very interesting. I guess I foolishly put up my hand thinking that sleeping as long as possible was better for you. But I guess for those that do perhaps typically sleep longer than the 7 or 8 recommended hours, are we better off setting an alarm for that sort of 7 to 8 hour period, or sort of seeing out that sleep naturally?
Yeah, I think it's important to be really cautious about this. I mean, that question is all that's asked. They have not monitored sleep in those studies for the vast majority. So it's just when you ask people that question at a population level, how many hours on average do you sleep? Now, they may misreport it. It's just how long they perceive themselves sleeping. So we're not at the point where we can say, don't sleep too much. And we don't actually have a mechanistic, plausible reason why sleeping a long time might be bad for you. It might be a marker of something else. So I think, no, don't go setting your alarm, because it'll make you feel cranky. Yeah, get what you need.
I don't, to be honest. As a lead on from that, I've sort of heard, I don't have one, but apparently you can get apps that have these alarm processors that sort of listen to your sleep pattern, I guess, and will wake you up slowly at a more appropriate time. Does that make any scientific sense? If that's...
Yeah, so those apps, most of them, well, to my knowledge, the ones I know of, work on movement. So they use movement as a proxy for your sleep stage. So when there's more movement, you're in your lighter stages of sleep, and makes sense that it's much easier to wake up in a lighter stage of sleep. So what they do is you can set an alarm, and then the device monitors, maybe within half an hour, either side of your alarm point, or maybe just before. And then when it senses a lot of movement, it makes the alarm go off and makes it feel like it's more refreshing to wake up, because if you're waking up out of deep sleep, it's a bit difficult and you feel pretty groggy. But if you're waking up out of dreaming sleep or light sleep, you feel much better. So that's sort of the basis that those apps go off. So they need to be in the bed with you.
Down the front here. As a group of one, I tried that app and it worked, I have to say. I found it was quite effective. The only problem is I couldn't afford the window when to get up, so I stopped using it.
I'm a consumer, as you may have noted, and I was diagnosed with obstructive sleep apnea 20 years ago at the REPAT, so I'm incredibly grateful. And I've been using a CPAP machine all that time, and I credit that device for my intellectual longevity. Didn't add any points to it, but it's kept it fairly the same. But as a consumer, I hate the damn thing. It's uncomfortable, it hurts, it presses into bits of my cheek that don't want to be pressed, and it's very unsexy.
This is why we go to work every day, to make alternatives. Yeah. Yeah, real sexy. Yeah. You've just joined. Yeah.
There were, yes.
Thank you, Danny. That's a very good work. So what is the interrelationship between the snoring and the sleep apnea? Does it predispose someone to sleep apnea?
I can try and answer that. So snoring can be different to sleep apnea. So you can have snoring and not have a sleep disorder. So usually if you're on your back, your snoring could be more severe. So sleeping on your side might make it a little better. Another thing is drinking alcohol can cause snoring or worsen snoring. With sleep apnea, what's happening is your airway is narrowing to a level that makes it so that you're getting insufficient ventilation, so you're not getting enough air, and it's basically waking you up during the night so you can breathe better. And your oxygen levels drop as well as a result of the pauses in breathing. So you might get narrowing to a degree where you're not getting enough air or complete obstruction, and then it's cyclic, so it happens again and again during sleep.
Thanks for the lovely talk about sleep apnea, but there's a lot more to sleep than just sleep apnea. There's a lot of people who have other sleep disturbances. I'm wondering if you can talk a little bit about the research on other things that disturb sleep, particularly narcolepsy. I know is now considered a continuum. It's not just, you have it or you don't. And also new new understanding about orexin and how that might regulate melatonin.
Sure. Do you want to talk about something insomnia work? Yep. Yeah.
I can talk a bit about the insomnia work that we do, which is, I guess, Aisha's other side of the coin, so sleep apnea and insomnia. So we've been doing a lot of interesting work around insomnia and recognising different types or phenotypes of insomnia and recognising the different types. So trouble getting to sleep, trouble maybe staying asleep or waking up too early in the morning, and really trying to tailor interventions in the same way that Danny talked about for sleep apnea. It's a very similar program in terms of insomnia. We've got some devices that we've been working on for the treatment of insomnia, so that THIM device that Danny mentioned, and also the light glasses. And I guess where our research is unique is understanding the role that the body clock plays in the development of insomnia and the maintenance. And that traditionally, when we've been treating insomnia, we've just been focusing on the cognitive and behavioural components of insomnia, and now targeting the body clock is really where it's at the moment. We're getting much better results in sort of a two-tiered approach.
Can you talk a little bit about orexin?
Sure. Yeah, so for people that may not be familiar with narcolepsy, it is a rare but incredibly debilitating disorder. Often takes a long time to actually be diagnosed because it's challenging to diagnose. It often comes in teenage years. These people are very sleepy during the day, and sometimes they have what's called cataplexy, which is again that intrusion of sleep at unwanted times. So, or sleep-like traits. So you might get a bit of relaxation inside of the face and so forth. So just showing that some areas of that switch are kicking in, and in fact those things can actually happen during strong emotions and excitement. You can elicit that, basically flipping you partially into sleep. So very, very sleepy throughout the day. Now, the way some very nice studies were done early in Stanford and other places to show that this group of neurons in the hypothalamus these are orexin neurons, or some people call them hypercretin. It was actually in some of these nice dog models that were done in Stanford. That basically these group of neurons, when they were gone, it mimicked the behaviour of narcolepsy and cataplexy. So there are some drugs now that target this. This orexin is one of the sleep-wake. I talked about adenosine and caffeine, but orexin is another one of these neurotransmitters that mediates how alert you feel. And so, yes, there are now orexin antagonists that are actually being used as sleep promotion aids, and there are also some orexin agonists to try and help with narcolepsy that have got some studies underway, I believe. But Doug, do you want to comment a bit on the clinical side with narcolepsy?
Yeah, it is an interesting condition, and as Danny said, it tends to occur, in teenagers or in very early adulthood. The trigger for it is not really well understood, and it may be viral infections as one thing, and in fact, the H1N1 flu epidemic that was around caused a lot of childhood narcolepsy in China, as it turned out, and that's caused a lot of interest. So something is triggering this thing, but it seems to be an autoimmune disease where the body attacks these orexin neurons that Danny was just describing, and they become depleted in the brain, in that really unique little part of the hypothalamus, and then causes this whole clinical syndrome. So the presentation, as Danny said, is dramatic. You have teenagers who can't stay awake at school, and this cataplexy condition, which is typically actually induced by laughter. That's the emotion, but sometimes anger will do it. And people literally can fall to the floor. We had a teacher, for example, who was a patient of mine who was actually debilitated and had to leave teaching because the students cottoned on to the fact that if they made him angry, he couldn't stand up anymore. So he would have to grab the desk and fall down. So they really got his measure, and he just could no longer teach. So cataplexy is really quite a dramatic symptom, but sleepiness is the major, debilitating problem for them.
I'd like to ask if the panel has an opinion in regards to, over here, young children and young adults who've grown up in the digital technology era, or people who are shift workers, and the impact of sleeping from environmental behavioural aspects. We are constantly being told in the media that these people are not getting enough sleep. Do you have an opinion on that one?
That's a good question, and I think it varies, and the media is good at making kind of blanket statements about these kind of things. So maybe start with teenagers. So we know that a lot of teenagers suffering from not getting enough sleep, and some of the main reasons for that is because during that developmental time there's a tendency for our body clock to delay, and so it makes it more difficult to fall asleep at a time that's early enough to get enough sleep before they need to wake up to go to school. So they're getting a lot of truncated sleep during the week and then catching up on sleep on the weekends, which just promotes the difficulty falling asleep again during the week. So there's that kind of problem that happens in adolescence, just as a part of being an adolescent, and that can trigger into early adulthood. And shift work is very difficult too. So especially if you're on rotating shifts, it can be very difficult for your body clock to travel with the times that you're wanting to sleep. So a lot of times shift workers are sleeping in opposition to their physiology. So they're trying to sleep when their body is saying you need to be awake, and they're trying to work when their body is saying you should be asleep. So they are right in saying that those populations are at risk of not getting enough sleep or not getting very good quality sleep.
It turns out, I mean, the smart lighting now, there's all sorts of things at an occupational level that you can do to sort of optimise performance and alertness, and then wind you down at other times too. We know a lot about the science about this now, so it's about implementing and translating that into occupational setting, which there are some good examples of that happening around the world now.
Hi. I'm just wondering, there's been some research recently, I think, about chronically poor sleep reducing the length of your sort of telomeres, and I'm wondering if when you get to sort of being such a long-term poor sleeper, if there are irreversible sort of changes on a cellular level, or if you can actually make gains by improving your sleep.
We've not, done any of that work here, but it's been reported that chronic poor sleep causes these telomere shortening, and that the idea is that it might promote accelerated ageing. The paradox, of course, is that we're all living longer and we're getting more sleep disorders. So, and I don't know of any study that's been done either in animals or in humans where you've actually induced more sleep, experimentally, to see whether there's a reversal of this effect. I mean, that would be quite a difficult experiment to do. So yes, the idea is out there that poor sleep does cause shortening of the telomeres. Yeah.
I'm wondering if there are any gender differences in sleep disorders, in particular apnea, but others, and in terms of how it manifests, or how it's comorbidities, things like that.
I mean, there's a lot on this, but I think probably you should say that one of your first PhD students did her PhD on difference between Amy Jordan and difference between men and women.
I mean, the two commonest sleep disorders that we see are sleep apnea and insomnia, and they have actually opposite gender ratios. So men are more commonly affected in a ratio of about 2 to 1 for sleep apnea, and it's the other way around for insomnia. And the reasons for that are not entirely clear. In sleep apnea, we think one of the issues is the way in which we distribute body fat when we gain fat. Men seem to gather it centrally around the throat. Women tend to put it around their hips, well away from their throat. That's one thing. And then the other hormones are probably important. Female hormones before the menopause are probably protective, because we see a rise in sleep apnea postmenopausally in women. The reasons for insomnia being more common in women than men, I'm not certain about. You might like to comment on that, Nicole. Yeah.
Yeah, I think we don't know. There's not a good understanding of why it affects more women. It could be a reporting bias, so more women are reporting having sleeping problems. We also see an overlap, a lot of insomnia with mental health problems, and it could be coming out that way, but we're not sure why it affects more women than men. Yeah.
And I'll also say that, you know, a lot of these studies have been predominantly done in men as to, you know, why people get sleep apnea, and as well as the treatment side. So it's very much an under-studied area, and my colleague, medical director Bob Adams, is actively trying to, you know, study that very phenomenon, because it probably is there's different causes and different manifestations, and, you know, the treatments probably are, I would predict, are not the same for men and women, and it's really important that we figure that out. Yeah.
Thanks again for your talk. I'd like to bring up another area of sleep problems, nocturia. When you've given your patients information about reducing their fluids before bedtime, but they're still peeing a lot at night, who's the best people in Adelaide to send your patients to get those physiological issues sorted out that may be behind their nocturia?
Yeah. Don't you want to comment on the clinical one?
I can't give you a name and address. But there is one interesting observation amongst men who have nocturia, I would think women as well, who have sleep apnea, is that they get an interesting phenomenon, that is that they release a hormone from the heart because of the sleep apnea that causes more urine to be produced during the night. And, you know, we've seen clinically many men who have come to us who have had prostate surgery to try and deal with this problem. It's been a failure. And when you treat their sleep apnea, they don't get up and pee at night. And it's an interesting phenomenon that because of this stress that you saw from the video, the great vessels in the heart are being put under stress while someone's trying to breathe against an obstructed airway. That dilates the heart and it releases this hormone that causes them to pee. And so they get up repeatedly to pass water at night. So that's been well established over a number of studies.
What about those who've had a sleep test and still having an issue? Obviously they need to go and see someone.
Yeah, I think if they haven't had their sleep apnea properly addressed, that might be one thing that they could do, yeah. But of course, you know, a very common cause, of course, in men is prostate problems, you know, so that needs to be looked at too.
Yeah, well, that's where I work, so we've dealt with that.
Yeah.
They're still peeing at night too often post-prostatectomy.
Think about sleep apnea is what I'd say. Yeah.
That I do, but some say I'm on a CPAP machine already.
Oh, okay, right. Then it's getting difficult, yeah.
Anti-muscarinic.
Yeah. You had some interesting stats at the start about the amount of sleep and the equivalent of blood alcohol levels. Does that mean people with sleep apnea who are living with it untreated, which would be a lot of people, I imagine, are they effectively living their lives in different degrees of being the equivalent of being under the influence of alcohol?
Look, en masse, the answer is yes, but we know that, and that's actually another focus of the lab, is the susceptibility to sleep impairment or sleep loss or sleep disruption. You can take someone with very severe sleep apnea, measure their performance and alertness, and they're performing normal. And then you can take someone who's only got mild sleep apnea and they're performing terribly. So there's different, for the same exposure, there's different vulnerability to performance and alertness impairment. And Andrew Vaculin, who's an Nhmrc Career Development Fellow, he's got a program of research that's really about trying to develop biomarkers or little signals in the body that will allow us to see who is most vulnerable and who is not. So yes, on average, you know, people with untreated sleep apnea are 6-7 times more likely to crash their car with severe sleep apnea. But, you know, in some of the studies anyway, but on an individual level, it may be an issue for some but not others, and hence, you know, the challenges around recommendations and clinical care around that and public safety.
Thank you very much for your important work. So talking about insomnia, maybe it's a very naive question. Looking into internet and finding so many recommendations, how to treatments, it starts from having a